Good afternoon and welcome to this live broadcast. We are interrupting your afternoon programming normally to bring to you a discussion that is quite informative and interesting to hear, because we are going to be focusing on understanding the impact of COVID-19 to sexual reproductive health services access across the country and across the board, whether it's young people, women, or even the youth. My name is Walter Mwesije. We have Maureen Nambalira on sign language, and I have in studio with me Dr. David Okello, who is the Director Non-Communicable Diseases and Health Aging at ACHEST, and I have Dr. Tony Kapsandui, who will be joining us via Zoom. He's the Program Manager and Reproductive, Maternal and Newborn Child Health and Nutrition at AMREF Health Africa in Uganda. Dennis Chibira is the Executive Director of HEPS Uganda. And finally, Dr. Robert Mutumba, the Principal Medical Officer, Reproductive Health and Infant Health Division of the Ministry of Health. Now, we have just a brief video which is going to cast light of what has been happening since the outbreak of COVID-19 to date in terms of accessing sexual reproductive health services across the country. Take a look and we'll come back and have the discussion.
Reduced access to sexual reproductive health care during COVID-19 pandemic has had severe consequences for young people, especially adolescent girls and women. One such consequence is an increase in the number of unintended adolescent pregnancies, which in turn could increase pressure on girls to marry at an early age. Some reports, including that of the United Nations Population Fund, show a significant impact as a result of constrained access to SRHR services. Eastern Uganda, Busoga in particular, has had the highest reported cases of teenage pregnancies, with Luka district alone reporting more than 600 cases. West Nile and Ankole regions have also reported many cases.
Youth-friendly services cannot be accessed easily. Contraceptive methods like condoms cannot easily be got the way we used to. Young people have fear of going to the hospitals because they think that it is where COVID-19 patients reside, and they think that is where they would also get COVID from. We may not be having masks, and we cannot access services that are in the hospitals.
Abalenzi bakozesa ino ebiragalalagala olwokuba nti tibali kujja ku masomero ate n'ebyokukola bitono babasibira waka.
The police has since received 4,442 cases of defilement reported between January and April 2020. This is an impact on sexual and reproductive health and rights. The crisis is affecting the delivery of sexual and reproductive health services around health facilities in the country, especially in the way they operate. Some have been closed as others convert to handle only COVID-19 related cases. The impact of the measures to manage the spread of COVID-19 disrupted the supply chains and restrictions to freedom of movement.
Young people, even other patients, feared to come to the facility because they thought maybe all the facilities have COVID-19.
In the time of the lockdown, the graph went down in the demand for family planning services and commodity services actually.
The consequences of that was, and yet some are yet to be seen, high numbers of pregnancies, infections with STIs and STDs. It put the lives of these, especially the young girls, at stake. Majorly, the problem has been the variety, especially for sexual reproductive health services, even when it is the same for other services. But you know, when it comes to sexual reproductive health services, particular individuals respond, especially the women, on issues of family planning, respond to particular methods differently, others with adverse effects. So there is need for having a variety.
HEPS Uganda, partnering with other organizations, including AMREF Uganda and ACHEST, implemented a 5-year health systems strengthening advocacy project to promote participatory advocacy for effective policy implementation in 6 districts: Kabale, Chisoro, Lira, Dokolo, Serere, and Soroti.
Ensure that family planning commodities are available in all health facilities and all the method mix are available, so that whenever a woman has already taken on a method, should at least always get that method to avoid taking on a second one, or even failing to continue with the method when it is not available in the facility. Then another issue was to ensure that young people, adolescents, access reproductive health services and information, so that they don't mess up with their lives, so that they can also know what to do in case they have their body changes, in case they need information, where to access it.
Between March, during the lockdown, up to about September, we've had close to over 2,000 condoms dispensed, about 2,900 of them. And then about 1,400 users of family planning have been here in different areas, the IUDs, the Implanon, the Jardel, the Sayana Press. And so their advocacy has also helped us to make sure that we have the stock and eliminate stockouts.
Kawale district did not have any budget for family planning. Worked with them, worked with the district budgeting desk, and finally were able to include in 5 million per year for advocacy for family planning uptake.
Most of the family planning methods were not fitting these people. People were fearing to use family planning. When you go, most of the drugs were getting expired in the hospital.
Some health workers do not have skills for providing these family planning methods, especially long-term methods. But we were able to work with the project, advocate for this, and the district would take it up, looked for the other partners who would train. And I'm happy that most of our health workers were trained.
Youth champions have been trained to help us talk to these youth about the sexual reproductive health and where they can get the services. Okay? And then we have the VHTs who are there, and those ones live in the community. So we needed to continue sensitizing them on both issues of COVID-19 together with the sexual reproductive health, so that the services all flow at the same time, and they should get the right services at the right time.
Even without a pandemic, women in Uganda face barriers to accessing sexual and reproductive health services. COVID-19 has placed an extra strain on this issue, while many services shut down to maintain physical distancing and avoid further infections. Women still very much need SRHR products and services. Life goes on and sexual interactions continue, even amid the challenges COVID-19 presents.
Welcome back. If you have just joined us, you are watching a conversation that is going to include information on access to sexual reproductive health services across the board for young people generally in the country, because Uganda is known as the world's, the country that has the world's youngest population. So it is a fact that people require these services. But you can also follow the conversation on our online platforms. We will be having some engagement on Twitter. You can also follow the conversation with the hashtag SRHR services for adolescents. Send through your comments. And I have different experts from different fields. Dr. David Okello from Achest. I know Achest, one of the objectives is to boost institutional capacity. And what we've seen in this video is, the impact of COVID-19. Generally across the board, everywhere in the world, COVID-19 had, showed some bit of impact, even in the first world countries. But when it comes down to a country like Uganda, and we have measures put in place, then we see some adverse effects. For example, the report from police that over 4,000 women, young girls, were raped, means that they are going to have a very long time, you know, a very hard time of their future going forward. What do we understand from, you know, the impact of COVID in exposing the weakness in the systems generally?
Oh, thank you very much, and thank you for inviting me to participate in this extremely important discussion. Of course, COVID found our system a bit struggling, but it has gone worst with COVID. And you are right, the issues that have been highlighted in the video you have shown are real issues. At Achest, we have a pilot project in the community in Ngora, where we are interacting with community members, training village health teams to really mobilize the community to take charge of their lives. Communities have a role. They should not be waiting for things coming from headquarters only. They have a role to play in all those things that you showed on the video. Teenage pregnancy, it's a big problem. It's all over where we are. This is perhaps one of the major problems we are seeing. You know, the schools were closed and young girls are at home, kind of redundant, and they're kind of passing time with friends and so on. And we have seen a lot of young girls getting pregnant. Of course, rape is a problem, and many other issues. The impact has been in phases. During the lockdown, it was really bad. You know, what you're talking about, services levels got reduced, transport systems were cut off, you know, supplies from the headquarters became problematic. We were working with an RDC who became like the ambulance driver. Everybody's calling him at midnight to go and pick a pregnant woman and so on, because there was no other transport system. So this is a real problem, and I think we need to deal with many other aspects of it. The HR, human resource capacity that you referred to, were also diverted. Attention was diverted from normal services to dealing with COVID. You know, nurses, doctors were kind of asked to look after COVID. Yet other people also had their problems. You know, women were getting babies and so on, but the number of people working on them got extremely compromised because attention was pushed to COVID. Commodity issues, family planning, supplies also got compromised. So this is a problem that I think we will live with it, but there are ways around it. And when we come to further discussion, I will tell you how our impact in the communities where we're working. Once the community is switched on, discussing issues of how to look after their children, how to take care of preventive measures, they really, health-seeking behavior goes up, they get more tuned, and they really help the health system in general, how to respond to COVID. I think the government is moving towards empowering communities to look after themselves. Not everybody, in our view, requires to be admitted to hospital. Yeah. We should accept the reality that those who are not very sick can be managed from home, and communities can handle this. Community can do contact tracing. Community can mobilize behavioral change. One of the things I noticed in the communities today, when the elections, primary elections were going on, people basically ignored the issue of COVID. And I think we should deal with this properly. Burial services. If you go for burial, people kind of behave like there's no COVID. And we need to mobilize communities to look at this as a problem we can handle. And they can enforce the SOPs that have been put up by the ministry. So I totally agree. This is a major problem, and we should pay attention to it.
Okay, so the impact is high, and you mentioned something that is very interesting, our health-seeking behavior. Generally in the country, we are not yet where we want to be in terms of health-seeking, but if we have that proportion of people, you know, trying their best, despite the hardships previously, you know, distance from the health facility, and, you know, if you'll find a health worker, that's also another thing. But all those factors aside, we've managed to reach the hospitals, and the issue of access is where I want Dennis to chip in, because in the video we saw the gentleman saying that access does not only stop at availability of the commodities, but the commodities that people want. You have pills, people want condoms. You have condoms, people want, implants. What have you seen on ground?
Thank you, Walter, and good afternoon, viewers. I think I'll answer your question, but I want us to go back a little bit, even before COVID came in, how our health system, how we were standing. First of all, in terms of the health expenditure, for every 100 shillings on health, even before COVID, households or individuals were already paying 40 shillings. And more than another 40 was paid for by donors. With COVID, donors are also focusing on their interests back at home. We know that a number of informal businesses, and mainly these small businesses which are actually manned by women, most of those, and some surveys say up to 70%, closed down, which means the money available for discretionary expenditure reduced. When we come to, of course, the lockdown had a lot of effects that people were not able to go to facilities. They didn't have even income. We were at home. So during the lockdown, services really went down. Demand really went down. As we've opened up the economy, we see that demand has started to grow. But again, going back to your question of choice, the choice that is available to a user. First of all, want to say that, again, even when the economy and the system was opened up, that you find some facilities were repurposed to only handle COVID. Others, you saw some of you even closed down because some health workers got sick, so some facilities closed down. So, of course, certainly, even the physical availability then reduces. But also, COVID impacted the supply chains globally. And so, the issue of choice is one where we've not paid a lot of attention, because even in our facilities, ordinarily you will find pills, injectables, maybe condoms, maybe 3 to 4 items. So it's limited. But now for even these younger people who are locked down at home and have no way of even getting to a facility, or are not even supposed to move, that certainly, it puts them at a more vulnerable angle.
Okay. We will hear from Dr. Robert Mutumba from the Ministry of Health. I'm sure the ministry has been, stretched, and we know literally every day, year in, year out, that's financial year, you've been operating on, constrained budgets. Now we have COVID-19. You're dealing with a backlog of the previous burden plus, a new burden which we're actually learning from. But where do we get the balance? A lot of focus was put on COVID-19, and some of these things were left out. Have you made an evaluation to actually see the burden that was created during COVID-19, especially regarding access to sexual reproductive health services?
So thank you so much, Walter. Indeed, we've really had a significant bite in terms of the impact of the pandemic. So there's been really a serious gross disruption in access to healthcare services, not only SRHR services, but in terms of the support, yes, we really had to make revisions within budgets and work plans to see how best to to handle or address the emerging issues out of the pandemic. Particularly, we also want to thank partners, development partners and implementing partners, but also individual donors have really come to strongly to support the interventions, especially within the lockdown period, but also within this particular period where there was a lifting of the lockdown. But we, at the time when we are now emphasizing the continuity of the essential healthcare services, of which SRHR is part. So we've really tried to look at review the work plans, but also internally there has been reallocations of budget, especially to address critical issues in the health service delivery.
Okay, there are some, sticky issues that have been prevailing. For example, in the video we saw a gentleman who was saying the acting DHO of Kabale said they didn't have a budget for, sexual reproductive health commodities, and the health workers were actually not trained on how to administer these services, meaning there wasn't a corner for young people to get help when they need it. These are issues that have been available, they have been existing even before COVID-19. What is the problem? Why don't we deal with, the existing issues as we also head into COVID-19? Because one would want to think that the excuse should not only be benchmarked on COVID-19. If there was no budget for these services, for example, in Kabale Hospital, then the excuse won't be COVID-19. What is the ministry putting in plan?
So the plan now is the integration. Amidst the limited resources that we have, what we are now strongly emphasizing is the issue of integration. You talked about having an adolescent corner at a facility. Again, we've tried this out, but again, more challenges come up. For example, when you create such an adolescent corner, again, it will call for more dedicated health workers to work, to provide services within that particular corner. And then as you're focusing on creating an adolescent health corner, the elderly are also advocating for their own corner. So I think what the ministry is now really strongly advocating for is how best can we integrate, for example, SRH services with HIV, GBV, and we again have a number of integration initiatives. But I would like to, I acknowledge the gap. We have a funding gap. I know that partners have largely supported the SRH services, but the government continues to renew its commitment, and maybe in the upcoming financial year we will probably see an increment in the budget allocation for SRH, but also especially with the creation of the adolescent and school health division. I think that was a key step in the positive direction for government to commit and really ensure that there is a strengthened focus on adolescent health services. I'm
not certain Dr. David will agree with you when you say once you create a corner for the youth or the young people, then the elder will also want their own corner. And I will ask him to respond from the experience Archest has garnered, and of course providing skills and knowledge. How should these interventions be targeted?
A very important argument you're pushing here. I think integration within the health sector is important, but it's also important to note that health is not only handled by the health sector. Health must be handled across sector. We must promote intersectoral collaboration, sector-wide approach on issues of health. There's a lot of information in the education department, the Ministry of Education, Ministry of Agriculture. They have a lot of issues they deal with on matters of health. Gender-based, Minister of Gender, there's a lot of issues they deal with on matters of health, on sexual reproductive health. I think our advice and strong advocate is that matters of health should go beyond the Ministry of Health, should go beyond doctors and nurses. This is a social issue, and if we want to achieve what we have been preaching, we must involve all sectors, all departments of government, MDAs. If we want to achieve our SDGs, we cannot leave this to the Ministry of Health alone. We really must work across sectors. We did a study in Achest recently looking at how government departments are working. And you may be surprised, government departments tend to work in silos. You know, they get a budget for the Ministry of Health and nobody else would see that budget. Ministry of Education, Ministry of Agriculture. And really, I think we must get to a point when we begin to work as a team. We gain a lot, even in budget form, if we were able to share some of the responsibilities around sexual and reproductive health. I think it can be done. Completely right. The Ministry of Health should integrate their services, but we should also try and integrate and work across sectors on all matters of health. Health is in the center of SDGs. Without health, we cannot have a nation that is growing. We cannot have a proper economy and so on. We really must work to ensure that health is given priority that works for everybody. And we have also found that if you do bottom-up, if you start from the community level, right from the community level, engage the cultural leaders, engage the religious people, and civil society and so on at the grassroots, it works better. So integration, yes, but intersectoral collaboration must also be emphasized.
All right, and it's very clear that most of the work being done up country by, as regards the health sector, involves very many non-government organizations.
Correct.
Which support the Ministry of Health. So, and we have evidence of, people telling us that when COVID-19 set in, some of them were actually also stopped. They couldn't move beyond, curfew time. And these are like, you'd call them essential people.
Yes.
Out of Kampala, out of the city. I want to connect to Dr. Tony, but I've been told that his internet is not so clear. But we will try as much as possible to speak to him. And Dr. Tony, if you can hear us, we would like you to, highlight some of the challenges the health workers faced during COVID-19, especially regarding sexual reproductive health services, and what you as AMREF found out. Welcome back from that short break. Unfortunately, we will not be able to connect to Dr. Tony. His network is very, very unstable, but we will, of course, indeed share some of his thoughts when he puts them forward with us. Now, HEPS Uganda did conduct a survey about what has been happening regarding access to sexual reproductive health services during the COVID-19 period. And we have some of the results here. And what you see on your screen is the first poll, and the major question was, what has been the challenge young people faced in accessing sexual and reproductive health services during the COVID-19 period? The responses were from 3,476 people. And the biggest percentage said they feared contracting COVID-19, 30%. And, 22% of them said the service they wanted was unavailable. Now, that's the issue of choice. Some of them said the youth-friendly services at the health facilities were unavailable. And, of course, majorly transport challenges. That was very evident after the halting of major transport services and that was only referred to the DHOs to control transport during the lockdown. We're still in the lockdown, but of course it has been eased over time. And as you can see, 13 people there said they didn't have money to pay for services. We will come to the issue of paying for services because the Ministry of Health has representation. They will tell us if it is really true that people are supposed to pay for these services. The second poll, the question wanted to know the affected how COVID-19 affected access to sexual and reproductive health services in the different parts of the country. The responses were about 2,641, and 33% of them said all sexual and reproductive health services were not available, and some of them were not available. Those tied at 33%. 19% said they continued to receive the services, and of course this was evident in Lira. We got some information that the health services there continued operating normally, and of course you saw the doctor in the video saying that they managed to distribute condoms, and 15% of them did not know. In the final poll, 2,101 people responded to what the best way to sustain the provision of quality sexual and reproductive health services to young people should be or should have been during COVID-19 pandemic, especially when the lockdown was on before it was eased. Now, most of them want the youth-friendly services closer to the people, and the Ministry of Health will respond to this. 21% of them want to improve availability of sexual reproductive health commodities and medicines, but also training health workers to provide youth-friendly services, reduce the cost of the services or medicines, and provide more information about the available services. I want to start with Dr. Robert Mutumba on this one. We have, quite a number of people saying they were being asked for, money, and the unavailability of youth-friendly corners in these facilities. How do you respond to that? Are these services supposed to be paid for?
Yeah, thank you so much. Again, when you look at the healthcare system in the country, yes, we have the public and the private, but also for the public facilities from the level of general hospitals and above, we have the private wings, sections where people actually pay. Yeah, but ideally, in public health facilities below general hospital, that's health center 4 and below, services are actually supposed to be free of charge.
Or subsidized, do you want to say probably?
No, they are free of charge. They don't operate private wings. So a young girl to conceive, but now that she's presenting with a pregnancy, what we are really trying to do is, again, to ensure that all health workers are actually trained on the provision of what people normally term as adolescent-friendly services. And again, it's in line with the issue of the corner that I talked about, that the focus of the ministry now is to ensure that health workers are oriented on being youth responsive. For example, so that at each and every service delivery point, let's say in the HIV clinic, the health worker who is providing HIV care and treatment services should be able to appreciate the needs of this adolescent HIV positive young girl, even when she's presenting at the HIV clinic, because when that happens, we have now these young people actually attending almost all service delivery points within a facility. And in terms of we would then be happy to see each of the health work actually being able to positively attend to this young person. So that youth, the youth responsiveness is what we are trying to ensure, that we have a critical mass of health workers across the country trained. It's been largely partner supported, and in most of the regions where we have partners that are biased to SRH, but also with the support from many donors and agencies that really have a bias on SRH, is where we've had many of the health workers trained. But through the adolescent and school health division, we are trying to do a training needs assessment. The other time I was in Kasanda, and then I touched debates with the health center where, for example, you see many of the health workers are not trained. So if we do a training needs assessment, again working closely with the partners, we want to bridge that gap so that health workers across the country are able to really provide services, again with that the friendly approach that is desired if you're handling a young person.
I know, Dennis, these statistics are quite revealing, and you know, they were conducted during the time when the lockdown was very stringent, including after some of the measures were eased. And as a team, what recommendations do you think the ministry should pick from you?
I think as the recommendations that have come up from the public are actually very revealing, and I cannot say much more than that, because it has come from the people. If you look at what the public has said, bring services closer. So in this case, are improved so that this young person, this vulnerable woman, is able to be in contact with someone that could be able to provide the service or advise. They've talked about training of health workers. I think we have village health teams. Are they also empowered to be able to provide this service? But also in terms of communication, how does this young person, how does this woman be able to talk to someone easily? So in terms of communication, so again, that goes again into building community health systems, that if a young person needed a contraceptive, is it possible that they could call someone? Or is it possible that someone will reach them and speak their language to be able to provide that service? I think if we focus on community education and empowerment, but also training of health workers, that will be able to go a long way.
Well, I hope when we are done with COVID, things like the call center will now be transformed and, you know, shifted to improving communication of that nature, like Dennis has mentioned. But Dr. Okello here, I want us now to, you know, touch the issue of sustainability. How do we ensure that, you know, we have sustained response to things like sexual reproductive health that we have seen now is lacking in a way? You would say the ministry has not given it all the emphasis it deserves, but it holds much more to the public, because if the police says 4,000 girls were raped during the COVID-19 period, and of course the stringent months were about 2 or 3, that means we will have a burden of unwanted pregnancies, you know, abortions, and that directly also has an impact on the economy, you know. So it's really a very big chain that becomes problematic. How do we find solutions to this?
First of all, the slides you showed are very informative. All the issues raised there in terms of challenges that the youth are facing, in terms of even solutions of what needs to be done, I think they're real. your question, I think my biggest push would be, let's switch on the communities. Once the communities are switched on, most of these problems can be resolved. You know, teenage pregnancy, you know, girls and boys are running away from their villages. They're running to trading centers. Nobody's guiding them. Let's switch on our communities. Let the elders start talking to these people. Let our cultural institutions revive the old idea of bringing up a child. It's a community responsibility. We cannot just leave it to health workers to deal with this problem. Pregnancy can be prevented once children are brought up properly and they know the do's and the don'ts of life. At the moment, the community is disintegrating. You know, cultural institutions are disintegrating and the children have no direction. I think we should revive our community systems. I think we should revive our primary health care approaches so that we do not wait until the girl is pregnant and we start responding. I think many things can be prevented if we switch on our communities, our household people. People are not talking to their children. People go out, they drink, they come back late, they don't know what's happening at home. Health starts in the home. Health starts in the family. If people are switched on, if people know their responsibilities, I think that's the only way we will sustain some of these problems. At the moment, it's not working very well. You know, in many trading centers, you go find young people seated on the roadside watching videos, doing what they don't even know when to go back home, and nobody guides them. Nobody tells them this is not appropriate. And also, in some homes, people are turning against their own children. People, you know, relatives. The defilement story you're talking about. I think our cultural institutions should come back strong to talk about how to bring up our nation, how to bring up young people. It's not working well. In the past, it was very good, but now it's kind of washy-washy. And for me, if we can strengthen our primary healthcare activities, village health teams are revived and they're working well, cultural institutions are working well, local government is on board, and we are working across sectors. Everybody is involved, not leaving it to the Ministry of Health only. We will sustain this. We will start talking well.
You want to touch an aspect of sexual with the curriculum that can be followed. I don't know if there's been any achievement towards revival of sexual education in schools.
Yeah, yes, again, you remember very well what happened, but I think the issue was some of the statements, I think, that were in the the kind of content. They were out of political and the social context.
Yeah. Correct.
Yeah, but I think efforts have been undertaken to see that first of all, there were also misunderstandings, especially when you talk about so sex education. What does that mean? Sexuality education. Yeah. So I think the issues really arose from that level, but there has been a lot of effort in trying to clarify, because many stakeholders were asking very many questions. So in this sexuality framework, what are you going to be teaching our children? Those are things which are gradually being, again, there's a lot of dialogue on such, but hopefully very soon we'll have that out, and then maybe we can move. But the other thing I wanted maybe to add to this is that the ministry undertook a regulatory impact assessment, a RIA, but what came out of the RIA report is that the biggest issue around SRHR service delivery among adolescents is the lack of access to age-appropriate information. So that's what really strongly came out. And again, that was to inform the policy that we are talking about. So very soon, those are some of the aspects that are getting addressed, and we'll have a framework, I think, approved.
Okay.
I just want to add one point.
Yes, Doctor.
I think in all this discussion, and did not come up in your slides, drug abuse. We are seeing a lot of young children completely taken off on this drug business. They're smoking funny things in communities. They're not guided. That's why some of the issues about teenage pregnancy is because when young people get high, they have no control of themselves. We need to address the problem of drug abuse in communities, in the rural areas. It is a problem that this country will wake up to and find that we are too late. People are drinking and
you want to add anything on what has been discussed here, or you want to tell us about what you think should be the plan to sustainable supply of these commodities and services?
Certainly, the issue of sustainability, that's really important. I'd like to add a few bits. Right now, as a country, I think we are investing more in the aftermath and not the prevention, as Dr. Okello also put it. See, if you look at reproductive, maternal, and child health services, if you just look at the spending, for what we spend on in terms of maternal and newborn and child health, the government actually funds about 85% of that. But for reproductive, which means contraception and all that, 85% is funded by
donors.
By the donors. So it means government is more interested in after women have gotten pregnant and the children, but there would have been, if we invest, and studies have shown that if you invest in preventing these unwanted pregnancies, you reduce your expenditure by over 72%. So in other words, there are ways we could actually efficiently spend the little we have. So that's something that government needs to look into. However, the money we have for the country at the moment is still not enough. So government needs to look at health not as
an expenditure,
yeah, but as an investment.
Yeah.
Because if people are healthy, the country will have more productivity. So I hope our colleagues in the Ministry of Finance are also able to listen to that. But also we have to wake up to the reality that the donors are not there, the donors are leaving. We need more country ownership on the health system. We need more government to put in more money. In its basic form, and we build it as we move, instead of waiting to have a perfect system. That will go a long way in removing these out-of-pocket payments, that someone falls sick and they have to sell all the property they have because they need to get treated. So how do we ensure for health is something that we need to put a lot of focus on.
Okay, all right. Dr. Mutumba, do you want to conclude?
Yeah, thank you so much. Truly, COVID-19 has really negatively, heavily impacted on the healthcare system. But what I wanted to mention is that the Ministry of Health, through a pillar called the Essential Healthcare Services pillar, developed guidelines on the continuity of essential healthcare services, of which SRHR services are key. So what we are now doing is really through partner support, to ensure that health workers are oriented on these guidelines on how best to provide SHRH, but also in integration with other services, so that we again do not have many more other silent pandemics leading to the deaths. Family planning is a key pillar of safe motherhood, I agree, and I think again, we need to take a multi-sectoral approach.
Yes.
We are working with the Ministry of Education and the Ministry of Gender in many of the technical working group, at least for the meeting that I attend. And so because now one of the key impacts of the pandemic is the issue of violence against women and girls. And I've seen the Honorable Minister of State for Youth being proactively involved in many of the discussions, including dialogues we've had on teenage pregnancy. And I think there's a cabinet paper that was developed to see how best cabinet also gets committed into ending teenage pregnancies. So I think with the leadership having that shared vision and also us working together, we'll probably get there. Thank you.
Okay, all right. Our time is fast spent. We will have to meet some of the ratifications they have signed and agreements they have signed across the board. For example, funding the health sector, you know, up to 15%, which is something that has not happened here in the country. But of course, we hope that if we have more money to invest in the health system, then we'll have more productivity and we will reduce the burden of disease, you know, of the side effects of such things like, you know, poor access to sexual reproductive health commodities and services, which is a basic human right, actually. My name is Walter Mwesije. We heard Maureen Nambalira on sign language, and my studio guests, Dr. David Okello from Chest, Dr. Tony, we didn't connect to him because of, you know, internet connection, Dennis Chibira from HEPS Uganda, and Dr. Robert Mutumba. Thank you for joining us this afternoon, and we want to now take you back to normal broadcasting. Have a very good afternoon.